to mute our microphone, I guess.
Exactly.
I will mute you all in a minute.
I think that's the best way to do it. Thank you, Radko. I hope you didn't mute myself. Okay. I think that works. So I think we have we waited 2 minutes for the majority of people to join. So hello everybody, warm welcome from the RHEIA study team, and warm welcome to the investigators call, beginning of 2021. So I hope you are all doing well and you can hear me and you can see my screen, because we have a couple of slides to share with you. Talking about the agenda, we would like to walk you through the current study status per site and some overview on study enrollments. We would also like to share with you what we achieved in 2020 and what we would like to achieve in 2021. And then some more practical information on the second RHEIA protocol amendment, the ECHO core lab status and CT core lab status. And we would like to also introduce to you site scoring system, which will be implemented in second quarter. And then the main part of this call and main purpose of this call is definitely to share your experience and have opportunity to get in touch with the members of the steering committee and principal investigators and those of you who are already enrolling into the trial to really find out what's the best solution for your center to jump on the bus with us and be a successful RHEIA trial center. But first things first, so definitely it's not up to me to welcome you only, but it's also our lovely steering committee and both of the PIs, so probably I would like to now leave it to them to also welcome you on the call. So Hélène, Didier. Well, I think that Didier wants to have the Teams link again, so just received the message. So I would like to ask Radka probably
I will forward him the link again
to him. That he can join, but probably in the meantime, Hélène might be the one to represent the principal investigators team on this call.
Do you hear me?
Yes.
Hello? Yes. So hello, good evening to everyone. So of course we are two investigators with Didier Cheche, and he will join very shortly. So we have, as you know, we have twice a month we have meetings with Didier and the committee, and once a month we have a meeting with the steering committee to see how the study is going. And we are of course speaking about the amendment to the protocol, about the enrollment. We are trying to find the solutions and to encourage the centers and the investigators to enroll. So we are very pleased to have you today, and we are pleased also to answer to your questions in case you have some difficulties to include the patient in the trial. What I can tell you, for example, our center, is that it's quite easy to find patients from the cardiology department, because all the patients with aortic stenosis are discussed in weekly meetings, so it's quite easy to find a woman who is over 65. And we find in our center that the part which is a little more difficult is the part to have patients included from the surgical department, because they are not all discussed in our weekly heart team. So probably you may have this kind of same difficulties, and I think it's important to work together with the cardiologists and the surgeons to just to discuss all the women who are over 65, and I think this is the best way to enroll patients in the trial, despite the COVID, etc. We have these patients, and it should go fine for the next month. So I will leave Didier. Probably he join us to add something.
Didier, do we have you?
Not yet.
Probably not yet. He has some technical issues, which I really feel sorry for, but hopefully it will be resolved throughout the call.
Do you hear me?
Yes.
Yes.
Hello.
So unfortunately, I cannot. You can't see me because I only have connection with the sound, but it should be okay.
Same for me. No problem.
So hello everybody.
We
Thanks.
can hear you very well. Everything works.
Helen was just welcoming everybody on behalf of both of you. So probably if you want to greet the crew on this call as well, the floor is yours.
Okay. So I think it's. I would like to start by thanking each one of you who could attend this call, because it's quite important, because we need really to. You will understand that we need to speed up the enrollment for this very important trial. We did quite well despite the pandemic, but the time has come to take all the measures, to make all the efforts to just to really speed up and improve the enrollment.
Hey, this is Jeroen Baks. I can only do by phone. Somehow I don't have a link on the invitation. Sorry for that.
Hi, Jeroen.
Yeah.
Hey. We just saw each other for the other one. Yeah, I was not in my office. The other one I had to do by phone also.
I think that phone is fine because we have quite a number of people on the call. So I believe that it will even make it easier for everybody to have everybody on a phone. Sorry, yeah, go ahead.
Excellent. So maybe we could start with the slides. Do you see the slides?
I hope so. So definitely what we will start with is overview of the current status, because it's been some time. I think that the last call was after last summer when we walked you through the current status. So you deserve to know. Obviously, there are newsletters, but I would like to ask the team from SSS to walk us through the site status. Christine?
Yes, do you hear me?
Yes.
Okay, good evening to everybody. I want to show you a short summary on the site and country status. I will go through it in alphabetical order. Austria, we have 3 sites. One site, Graz, just joined recently. The other 2 sites succeeded to enroll 16 patients already. And the site Innsbruck is the 3rd top enroller, one of the best enrolling sites. So thank you to Nikolaus. Next country, France. In France, we have altogether 8 sites. All sites succeeded to enroll patients already. To enroll, I mean randomized patients. Altogether 52 patients were already enrolled. And the one further site in Poitiers will join still in March. Nearly everything has been settled. And yeah, as you can see, Toulouse, Didier is one of our top enrollers, and also the site from Rouen, Helene, is one of the top enrollers too. Yeah, so next country is will be Germany. Germany, we have 6 sites. 6 sites, 4 of them already succeeded to randomize patients. Another site will join is under set up. 23 patients could be enrolled. And also here, the site from Badenhausen is one of the highest enrolling sites. The 2 other sites, Hamburg and Lübeck, are actively searching for patients, but so far could not randomize a patient yet. Okay, next country, Czech Republic. There is 1 site already active. Czech Republic joined only end of last year, so it's a very big success. That's the site in Prague, ICAM, already could randomize the patients in spite of the pandemic. The other two sites received EC approval and they will be ready to start in March. Also, the contract has been settled, it's only signed, so initiation will be done in March. In Switzerland, we have 3 sites, 2 of them already could enroll patients. The other side also are actively searching for patients. So all 3 sites are really active, trying to find suitable patients. For Italy, we have 2 sites with altogether 10 patients already enrolled. The third site, Padova, took some time, but finally we now received EC approval. And now the verbal EC approval and the contract is pending. But we assume that also in March, April, the site will get on start. Ireland, we have 2 sites. One site succeeded to randomize a patient or ready for randomization. The patient was approved by the committee, but not randomized yet. The second site is ready to be initiated. So we are trying now to find an appointment for the initiation visit. For the United Kingdom, we have a site from Niluren actively enrolling with 1 patient. The other sites, unfortunately, are on hold due to the pandemic. You know, UK had been hit hard by the pandemic, but with the vaccinations coming, we are confident to have also here these other sites activated in the near future. Okay, so next country, Netherlands, we have 3 sites with 7 randomized patients. The site from Eindhoven is actively screening a lot of patients. So there are some patients in the pipeline, potential patients. So we also assume that in the next few days, the first patient from Eindhoven will come. The site in Sweden, Lund, they are in principle ready to start, but due to the pandemic, at the moment, they are not allowed to start. But also here, the situation hopefully will improve, so also the site will be able to enroll patients and start with the study. Finland, we have 2 sites with 1 patient. The similar situation like in Sweden. The sites hopefully will be able to screen more patients, randomize more patients, when the COVID situation will improve in this country.
Okay, thank you very much, Christine, on the overview. So in summary, what's the status? Beginning of this week, we had 116 patients enrolled, 50-50 randomization TAVI to surgery, out of which 100 was treated already, which I believe is a great achievement. And then we also have 4 patients with fully completed 12 months follow-up, so out of the trial. So this is something which we started to track as well. So now the ball is really rolling. We are initiating more and more sites, and obviously we went through some pretty difficult times being affected by the COVID pandemic, but hopefully the bright future awaits us in 2021 with the higher percentage of people vaccinated, and hopefully the COVID pandemic on the decline. Doesn't look like this as of today, but hopefully the future will be bright and we will be able to ramp up. With this, I would like to really mention our top 5 recruiters because they deserve applause, because they, despite the difficult times for everybody, they were able to enroll an important proportion of the patients to the trial. The first shared first and second place goes to Toulouse and Bad Oeynhausen with 16 patients enrolled in each of the centers. So really big thank you to the team of Tanya Rudolph and Didier Cheche, because they just did an awesome job. But not too far behind them is Innsbruck with their 12 patients, and Nikolaus Bonaros followed by Montpellier 1 and Bordeaux. So really like big thank you to all of you, because this was a tremendous job done in these very uneasy times. But what we wanted to also touch on is the reason, because we are collecting the information on pre-screening, is the reason why those patients are a pre-screening failure, and the majority of them is actually assigned as not eligible for both TAVI and surgery, followed by a category refused by the patient, which I believe in the times of the COVID pandemic might be also very much affected. And then other reasons like language barrier, mobility limitations, frailty, etc.
Yep.
But the not eligible for both procedures probably has to do also with finding the right approach and the right patient pool, as it was described also by Helene when she welcomed you. So it really, for this trial, it's really super important to have a very good heart team approach and very good collaboration between the Department of Cardiothoracic Surgery and Cardiology. Because if we look at the percentage of how many patients who were pre-screened have been also enrolled, is just 18%, which is a quite small ratio. So out of those 657 patients which were pre-screened, only 116 patients were enrolled. Obviously, the ratio is different in different centers, but if you look at our top players like Bad Oeynhausen, top enroller, and you compare it to Toulouse, top enroller as well, Bad Oeynhausen did tremendous efforts to find those 16 patients, where Toulouse is a bit better off because their ratio is almost 50-50. So there is some learnings which probably we can take from this information, and probably we can think about the best patient pathway for a trial within your own institutions. So this leads us to a recap of what we actually achieved in 2020. So we achieved to initiate, despite the COVID pandemic, quite a good number of sites. It was 28 RHEIA sites initiated. It's a very good number. And also 21 sites with randomized patients by end of last year. We also amended the protocol because after discussion with the principal investigators and the steering committee, some items came up. So the first protocol amendment was finalized in May and fully implemented, and also the second protocol amendment, which we will talk about later, was drafted in December, finalized in January, and now is ready for submission. So we would like to walk you through that during this call as well. We also achieved to publish RHEIA design in American Heart Journal in September last year. I think it's a very good reference point for all of you who want to use this in your talks or other manuscripts. And we also implemented some RHEIA study progress tracking tools. The majority of information is distributed using the RHEIA website and the private section for all of you who are RHEIA trial investigators. We also have, as mentioned already, regular meetings with the principal investigators and the steering committee, and obviously with all of you through dedicated monthly newsletters and also through the RHEIA website. Obviously, there is now time to boost again the study recruitment with motivational visits, with site motivational packages which you received after summer. We also heard you that you would appreciate having some information for your referral cardiologists. So we created a letter for referring cardiologists, And we had the first investigators call in August last year. So that was also a set of tools put in place to help you all with your site initiation. So talking about the second protocol amendment, I believe it's really important that everybody understands what's the key changes, because there were a few. And here I would like to ask again Didier, Helen, and the steering committee members to walk us through it. Didier?
So as you know, there's a quite burning discussion about the variation of the transcatheter because discharge and particularly when we compare the hemodynamic gradients to what we have on echo. What we would like to get within the trial is to try to understand what is going on when we do the hemodynamic assessment for the patients undergoing TAVI. So we try to standardize things. So after discussion with the steering committee, we said that we should try for every single TAVI patient to get a peak-to-peak gradient, mean gradient at the end of the procedure in a quite systematic way. And as I said, that we strongly encourage the operators, the physicians, to use a double pigtail recording, one pigtail sitting in the mid portion of the left ventricle, the other one 2 to 3 centimeters above the aortic valve, and record at the same time both pressures, the ventricular pressure and the aortic tracing, and record enough bits in order to get something that is quite stable and usable that we can interpret. And if the patient is on atrial fibrillation, try to record a little bit longer the tracing. So we would like to get that for every single patient. So it shouldn't be please feel free, try to do that. If you have any concern about the feasibility of that double pigtail recording of the pressure at your institution, this is the right time to discuss. We didn't feel that it was going to be too difficult, but tell us if you find any difficulty at your institution. So the second amendment that we discussed and we wanted to integrate within the protocol is a concern about potential for valve thrombosis, because this is another burning issue that is raising a lot of concern, and we need to track that. So the way that we would like to try to capture those patients is if we have a patient that has during the follow-up an elevation of the transvalvular gradients on transthoracic echo, this patient should be contacted and get another follow-up imaging, whether it be a transesophageal echo or ideally a contrast CT to confirm the valve thrombosis. And then what the protocol will recommend is a 3-month duration of anticoagulant, whether it be a VKA inhibitor or a NOAC, according to your local practice. And then the echocardiography should be repeated after 3 months of treatment to see what is the outcome, what was the evolution of the gradients, the transvalvular gradients, and ideally, if you could do so, to image the aspects of the leaflets to see if there is a resolution of the thrombotic aspects that was identified 3 months ago. And so as soon as you get this echo, the baseline echo with the diagnosis of leaflet thrombosis, please send these echoes to the core lab for analysis. And this is going to be the same also. The same for the follow-up echo. So this is another very important question that we should try to capture, because some of the you're going to see that a quite significant proportion of the patients, as we are dealing with ladies, will have a small annular area and as a consequence a small valve. And so if we see a difference into gradients between baseline and follow-up, we have to make sure that this is not related to the valve leaflet thrombosis. So do everything you can to try to confirm this and to try to treat the patient. If you think that this is necessary for your patient, because you are the physicians in charge of your patient. These are only recommendations, strong recommendations, but we will analyze everything at the end of the trial. Another matter of concern was the global pandemic, and some of the patients may face a COVID-19 infection. So we need to document that within the ECRF, and we have two possibilities. First one, if the infection occurred prior to the procedure, this is going to be only reported in the medical history of the patient. But if the infection occurs after the procedure, whether it be TAVI or surgery, this has to be considered as an adverse event and reported as so within the ECRF. So this is something that we need to be aware of. We need to track if a patient has a potential infection, COVID-19 infection, before or after the procedure. This is potentially going to have an impact on the outcome of this patient, so we should document that. So another point of discussion, because we will have time after the slide presentation to discuss all these points. Something that and at last, something that we didn't feel quite important to integrate or to consider as an adverse event is a transient modification, deterioration of the NYHA class between procedure and discharge. And for example, sometimes after surgery, we have a slight worsening of the NYHA class. It could also occur after TAVI, but if it goes back to normal, or if it improves during the follow-up, this shouldn't be considered as an adverse event. It's more at 30 days or ideally at 1 year. That is the primary endpoint analysis that we should consider the final NYHA class for our patient. So these were the protocol amendments that had been submitted. And so maybe before we move to the core lab, I think there are several points that we could discuss because we've seen a lot of slides. There have been a lot of events, a lot of very positive things during the past year. But we need to integrate this, we need to digest this, and we need to take conclusions, to drive conclusions all together to see how we can improve the screening of the patients and how we can speed up the enrollment. So I see that there is a quite long list of participants, and I really want to thank you for attending this very important call. If we, I know that in France, as we started a little bit earlier, there is quite a greater number of patients that have been included. Maybe we could ask to Florence Leclerc, if you are there. Would you like to share your experience? How difficult is it at your center to enroll patients? Do you have some tips and tricks that you could share with us?
Do you hear me?
Yes.
Hi. We have no difficulty to include the patient. The only one was when patient went to the hospital with an idea of the intervention that they want, because our physicians say us, oh, it's better for us surgery, it's better for us TAVI. It was the main difficulty. The patient accept the protocol very easy. It was very easy to have acceptation of the protocol. We have 2 patients who wait to sign to be included very soon, and the COVID pandemic was not a problem for us. Because we have inclusion, we performed TAVI during the pandemic, and so the main difficulty for us is really when patients have some information before hospitalization with the physician or the cardiologist. So I think the letter that Edwards make for the physician is important for me.
Okay, so clearly a need for just not to prepare the patient too much in favor of one therapy or the other one. And so I do agree with you, Florence, that the letter that has been provided for the referring cardiologist is really important, because most of the time this is one of the obstacles. Do you, Florence, or somebody else, did you also found that most of the patients that we enroll or screen are coming from the surgical pool? That is to say, the patients that should be operated on, and it could be easier to offer them the opportunity of 50% of chance of TAVI rather than the ones who are more directed coming from the cardiologic pool, who are more directly to TAVI. I have the feeling that we should really work with the surgeons as a team and screen within the surgical pool. Do you have the same feeling, Florence, or somebody else?
I have very few patients who come from a surgeon. The patient go to the interventional cardiology directly, and very few patients who come from the surgeon.
I agree with Didier. I think, as I said, as an introduction, for us, the main difficulty are the patients who are seen directly by the surgeons, because we don't have access, in fact, directly to these patients. All the patients with aortic stenosis are not discussed at our weekly meeting. The weekly meeting is only for patients who come from the cardiology department. So I think we miss many patients. So we're doing all the efforts we can to have a look at the patients who are directed to the surgeons, but probably we miss patients from this subset of patients. So exactly what you said, Didier.
Well, this is Philippe here. I'm glad to hear the comment from Florence, because if you remember, one of the concerns we had, initially at the beginning of the RHEIA trial, and before even COVID-19 struck us, was that maybe because of the approval of the TAVR for the low-risk patient, that is the population that we target in RHEIA, we may have difficulty to include patients in the randomization versus TAVR. But what I understand from hearing you is that it's not that much an issue, and as long as the patient is not too much prepared or biased in favor of pre-biased in favor of TAVR, right?
Mm-hmm. Yes.
Yeah, exactly. So another thing that we that was quite striking it's the screening failure rate that is quite important. It's almost it's more than 80% of the cases. So maybe there is something that we have to do as a group here to try to spare our time, because this requires a lot of effort to screen the patients, to go and try to consent the patient, and so on. So potentially, as we know now, it's more obvious what are the screening failure reasons, frailty, the patients with the bicuspid aortic valves, the patients who are not good candidates for either TAVI or surgery. So probably there is something that we could work, each one of us at our local institution, just to spare our time. If we have the feeling that the patient is not a perfect candidate for surgery, probably we should not consider that patient for enrollment within the trial. And that's, I guess that's something that we tried to do in Toulouse. That is to say that we proposed the study only to quite low to intermediate risk patients, below 75, 78. And these are good candidates because they come with the idea of undergoing surgery, and when you talk about this, you present the study, they are really happy to have that opportunity to get a transfemoral procedure. So probably there is something that we may improve in terms of who could be a good candidate, identifying what is the appropriate candidate? What are the who are the patients who should not be considered for entrance within the study?
Neil, you have a question?
Yeah, Neil Uren, thank you. I think we went through a process of assuming that if we brought our surgeons on board with the trial, that it would be easy to pick up patients who were being considered for aortic valve replacement. And I think what we've learned is that aortic valve replacement is a major activity for cardiac surgeons. So in our center, they do 1,000 bypass operations. 425 of these people have aortic valve replacements. We only do 250 TAVI. So, it's quite a big chunk of surgical activity. And so what we've realized, and what I have realized, is we actually have to pick up patients as they are coming to the surgical clinic, as Didier says, and say, you're referred for surgery, but here you have a 50-50 chance of having transfemoral or surgery, and kind of almost flagging that patient up in advance of the surgical outpatient clinic. Because by the time they come to the MDT or the heart team, the surgeons really only want to give up people that they think are frail and should have TAVI, and don't want to give up people in their 70s who they think they can do an aortic valve replacement on. So I think each unit will be different, but I think trying to pick patients up before they are too early into the surgical pathway is the important thing. And that's what we have learned. And I think what we will now do is pick people up. I can go to my computer and find out who's coming to a surgical clinic. And in advance, we can identify patients who are coming. We can let the surgeon know we found them rather than the surgeon telling us they're coming, because they come from outside our hospital. They come from our region. And so we may never have, the cardiologist in this hospital may never have seen the patient. So it's how we handle the regional structure in our center and pick people up coming to surgical clinics in advance. And I think if we do that, we can increase recruitment significantly. That was all I was going to say.
Thank you, Neil.
Thank you. Okay, that's nice. So maybe we can move forward.
So thank you very much for the great discussion. I think it's really important and valuable to share these tips and tricks and own experiences, because as everybody was saying, it might be different in each of your centers, but probably the building block or the cornerstone could be the same, or at least the direction to explore. But now let me ask Philippe Pibarot, the head of our Echo Core Lab, to walk us through some updates and statistics regarding our Echo Core Lab as a service.
Thank you very much. So can you hear me well? Yes? Okay.
Yes, good. Thank you.
So, of course, as you know, Echo is a critical part of this trial. Because not only for screening and eligibility, but in terms of Echo Core Lab, we assess the baseline and follow-up echoes. And of course, this would be important endpoint viable. So we need a good quality and completeness of the echocardiogram. This is absolutely essential for the outcome of this RHEIA trial. So it's not only to submit an echo. It's of course important to submit an echo for any pre-planned visit, but also the echo needs to be complete in terms of the images and signals that we require you to obtain, and also the quality is important too. So there has been some webinars to train the sites, and these webinars have been recorded and are available if you want to revisit them. There are also checklist protocol MOPs that describe, the acquisition, the image acquisition protocol. And it's so important to follow this protocol, because I receive echoes sometimes that have maybe too few images and that some key views are missing. And of course, this will eventually result in some important missing data. So we want to have as complete as possible echoes in terms of follow-up and in terms of the views that are in the echo. So important to perform the echo in accordance to the Echo Core Lab manual. And if you're not sure if you have the manual, well, you could ask SSS to resend and reread this manual. There is also, we provide a checklist that is a 2-pager that the sonographer or cardiologist doing the echo can have, in hand when he or she does the echo, and to make sure that they are not forgetting any view. The echo needs to be uploaded, as you know, in Ambra within 1 week after performance, and the echoes, the schedule is we need an echo, a complete echo and of good quality. Of course, sometimes the patient is not echogenic and it's not the fault of the operator, but try to optimize the quality as much as you can. So we need an echo at baseline, post procedure, so generally pre-discharge, 30 days, and 1 year, 12 months. So if because of course we also understand and acknowledge that we are in a pandemic time, and so in case the 30 days visit has been done remotely, well, we ask you to have the patient back on the earliest convenience to have the echo completed. So I think the message is that we prefer to have an echo maybe that is too late and to maybe outside of the predefined window rather than no echo at all. Next slide. So this shows some statistics about the completeness of the echoes. This is according to the documentation in the ECRF that are filled. So we have now up to 119 echoes at baseline, and this is about 92% of the patient with documented echocardiograms. Post-procedure, we have 94 echoes, which represent about 94% of the patients with documented echo. And then, of course, it's phasing out as we go. So 30 days is 81, so 93% of the possible patients. And for now, at 1 year, we only have 4 representing 75% of the patient with documented echo. So, of course, 1 year, it's relatively young. It's a relatively young trial, and for which we had a slow recruitment rate at the beginning, especially because of COVID. But I think it's important to maintain our effort to get the follow-up echoes, because what we've seen in other trials, I've been involved in, as you know, in the partner trials, is that there is some significant, let's say, missing follow-up echo at 1 year and beyond, of course. So generally, baseline, post-procedure, 30 days, not so bad. And then 1 year, you see clearly a substantial proportion of the patients not having their follow-up echo. And what we see is generally this missed follow-up in terms of echo are generally more frequent in the SAVR arm than in the TAVR arm. So we have to pay attention to that because, when patient maybe receive and that's the same for the treating physician, when you have a new technology, you may be more motivated to do the 1 year echo. When it's kind of a SAVR, well, maybe there is a bit of a looser strategy, and we've seen clearly, and that's bad because then you have a kind of maybe a bias in your comparison of TAVR versus SAVR, because let's say you have a 95% completeness follow-up in TAVR, but you have 75% in SAVR. Then you know that you have a problem. So I insist on that. We need to have a completeness of follow-up for both arms, and this is an effort that we should do. And also for the echo, when the echo is there, it's good, but it's also important that the echo is complete. So I think this was the last slide, and this is up to the CT Core Lab. Thank you.
Thank you very much, Phil. So really important. Yes. And again, any investigator at any time can send me an email if there's any question. If a given site need a RHEIA, we can organize a personalized webinar. And so again, my email is always open, and I'm always happy to help. Thank you very much. So now over to David. I hope we have David Masika on the call. Hello. So probably we lost him, but yes, we can hear you.
Can you hear me?
Yes. Hello, David.
Okay, hi everybody. I'm sorry I was muted. We have 2 slides for the CT core lab. So the CT part of the study has been added and proposed as an amendment that has been accepted. The principle is, and the primary aim of adding the CT is to look at the interaction between the calcium score and the intervention arm. So for that, we need to measure both the calcium score using non-contrast CT, and we would like to also collect the contrast CT to calculate what we call the calcium score density, which is the calcium score divided by the annulus area. So the primary aim is to look at the interaction between the CT calcium score and the intervention arm. We would like to do that in the overall population, but also according to the gradient, either high or low gradient subset of patients. And we would like, as a secondary aim, to look at the prognostic value of the calcium score on procedural result and 1-year outcome. If we go to the slide number 2. So for that, we need 2 sets of CTs. The first one is a non-contrast CT to do the calcium score using the Agatston method, and the contrast CT to measure the annulus area that you do for the planning of the sizing of the prosthetic valve. Both has to be uploaded in Umbra, and we will use Flimancio to calculate both the calcium score and the calcium score density. And that's what I have for the CT core lab. So we haven't started, so I cannot comment on any result or quality of the CTs. Maybe
but
Christine.
What we learn is that people are uploading mainly the contrast CTs, but we also that's a more a call for action. If you could also, if you have those CTs, to upload the non-contrast CTs, also super important, right?
Yes. What would be important first is to ask the centers how many are doing a non-contrast CT before. So how many non-contrast CT can be expected. And after that, we could have a better idea of how many patients we will deal with.
Yes. Any questions at this point to either an echo core lab or CT core lab to Phil and David? If something occurs at a later stage, please feel free to reach out either through us or directly to the both of them, because we believe it's really important to also now start working on the CT measurements and the calcium scores. So please, I know it's again an ask, but not only echo is important, but also upload of a CT. So with this, we would like to share with you the first analysis which we requested from the data set. And again, here I would like to ask Didier and Helen to walk us through it.
Okay, so I assume Hélène still can't see the slides, but these are data that we have reviewed.
If you agree to show, if you can do it. I am
you don't see them because it's interesting because I can see them.
I see them as well. It's visible.
Okay.
I will reconnect those slides. So just a minute.
No, it's okay. It's okay. We see the slides. It's just as Hélène is not.
Okay. Well.
Yeah, she can't see the. She doesn't have the screen, I guess.
Oh yeah. Well, now I get it.
So it was one of the question that we had tried to understand as we were dealing with a female population. What was the distribution of the annulus sizes and the type of devices, the size of prosthesis, every Ditavio surgery that had been implanted within these patients. And this is quite reassuring because if you look at this slide, first of all, we have a 50-50 distribution between surgery and TAVI. And when we look at the valve sizes and we take into consideration the areas, the vast majority of the patient had an area between 338 and 546 roughly between 20.5 millimeters to 24 something. So as a consequence, we had a quite significant number of big valve sizes, 26 and 29, and this was not really expected. Because we had personally the feeling that most of the devices that were going to be implanted were going to be 23 valve sizes. If you just go back one slide back from the surgical side, it's also quite reassuring because you can see that only 4 patients received a 19 millimeter surgical valve size. And so the number of patients with 23 or 25 or even 29 millimeter valve is noticeable. So it tells us that this was really a kind of team effort with the surgeons trying to achieve to implant the valve as big as possible for the patient to make sure that we have consistent and high hemodynamics in both arms. And this was quite reassuring. As you know, sometimes we are in gray zones between 2 valve sizes, and we tried also to understand if there were a lot of patients outside ranges and patients who were not treated with the appropriate valve size. But once again, quite reassuring data, because if you take, for example, the bigger population, the patients with an annulus between 338 and 430, these patients, among the 29 patients in this configuration, 27 had a valve size, a THV size, or a surgical size that was within the range, and this is quite reassuring. Only 2 patients had a valve that was outside the range, most of the time a bigger valve size. And so this is one of the conclusion is first that we should, as operators, try to push for the bigger valve size if this is safe for the patient, because we haven't faced any per-procedural complication, annular complication. So this depicts the maturity of the operators in every single center, including patients within the trial. So I have to congratulate you for that. And so if we could use bigger valve sizes, this could have a positive impact in terms of hemodynamics for the patient, but we have to remain on the safe side and try to still continue to avoid these annular complications.
Thank you, Didier. So I think that at least the first glance on at least some data points from the data which actually was collected. So let me quickly browse through the outlook for 2021, and I will probably skip also some slides because the time flies, and the main thing here probably or for sure is the potential room for discussion. So definitely what we will do to this year is a second protocol amendment. We will also we would like to make it easier for you with setting up reminders to for upcoming 12 months follow-up visits or even overdue follow-up visits, but also 30-day visits, including echoes and pending CTs to be uploaded to Ambra. We don't want to bug you, but I believe it's good if people just know that there should be a patient coming for a follow-up visit. Also, we added a couple of new sites to help with the enrollment rates. Because the enrollment curve is expected to ramp up, and especially now at the beginning of second quarter, the curve starts to really incline. So in order to help you with that, we also added a couple of new centers, but obviously we also count on the pandemic to decrease in order for us to have the curve nicely increased. I believe the patients' enrollment strategies have been discussed thoroughly. So let me go straight to the scoring system, which I mentioned at the beginning. because I believe it's important to benchmark, and it's nice to know how my site is doing as compared to the others. So this is still work in progress, but this is a system to be introduced in the second quarter as a performance evaluator, mainly for yourself and to also keep the good competitive spirit. So what the parameters to be observed and tracked are recruitment start enrollment rate, screening failure rate, because this is something which is a waste of time. So obviously, if your numbers are way higher as compared to the study average or even country average, then there is room for improvement. Also, the CRF completion, responsiveness, data quality, and completeness of ECHO 30-day and 12-month visits. The benchmarking will be towards study average, and then also we understand there are some country barriers, so also the benchmarking will be introduced to the country average. So hopefully this is something which will help all of us to know exactly where we stand, and then analyze probably gaps and be more successful in the study enrollment and study delivery. So definitely everything available on the RHEIA study webpage. So I encourage all of you to have a look regularly. And with this, definitely we came to an end of the slides and presentation, and I would like to open the floor for discussion.
So thank you, Jana. Hélène, do you have any comment, any thing you would like
I think I don't have any specific comment. I think the most important is to try to include more patients. That's the thing, we have to work on it. And it was good to have the information from Philippe, from anyone, from all of us, that you can contact us anytime if you have any question, any difficulty. And we have to find a way to find the women who are over 65 and less than, as you said, 78, who are, because over 78, they are directly referred to TAVI. So I think this is the most important part.
Yeah, definitely. And I do believe that the goal, the objective of 2 patients per month per center is achievable, and it's quite it's already reassuring, because when we see the curve, the inclusion curve, there is already a kind of steeper curve. So it seems that we the way the study is understood among the centers is getting better, and the patient that we should try to screen and enroll is more obvious to everyone, each one of us. So this is really positive, but definitely we need to enroll more patients, and this has to be done as a team. And I do really believe that the surgical team has to be involved, and I know that it's quite difficult in some centers. And so if you have any kind of issue, if you think that we may be of help by calling one of your partners, trying to discuss with your heart team, please feel free to reach out to us, and we will be very happy to help you to try to find these patients, because this is really truly a crucial study, a very, very important study.
Okay, so unless there are any other questions, and I hear none, it's the time is over. So thank you very much again for taking your time listening to today's information as we share them throughout the hour. And really, my wish is for all of us to overcome all the barriers caused by the pandemic and other things, and find the right way for the female patients to be enrolled into the RHEIA trial and to really ramp up the enrollment numbers and have a great data completeness. And really, as Didier mentioned, we can only achieve this as a team. So we definitely count on you to help us with that. So with this, I would like to thank you again for your participation, for your enthusiasm and willingness to be part of the RHEIA team. And I wish you a nice evening, and I'm looking forward to hearing back from you soon. Bye bye.
Bye bye.
Bye bye. Thank you.
Thank you very much. Bye. Take care.
Goodbye, everybody.
Thank you.
Bye bye.
Bye bye. Thank you.
Bye bye.